I'm super excited to have all of our extremely awesome people here to talk about such an important topic. And I'm hoping, since we're all coming at public health from a different sort of a lens, that we can have an interdisciplinary conversation. So, one quick thing. We would prefer if you would ask your questions in the chat during the first part, which is when I will be asking questions directly to the panelists. And then afterwards, um, there will be a time when you're going to be able to ask your questions live. Uh, on that occasion, if you feel more comfortable asking your question in Spanish, then you absolutely may. I can translate for you. And four of our five panelists are comfortable with the language, so they can choose to either answer you back in Spanish or in English. So, with that in mind, let's get started. And who better to introduce themselves and the work that they do than the panelists themselves? So, for this first question, I'd love to dive in and ask who are you, right? And what kinds of projects, that includes research, community interventions, and policy, do you do related to health disparities? And I would love to start with Carlota.
Hello, everyone. First of all, I wanted to thank you all, and especially the organizers, for the invitation, and Angelica for moderating today, and the other panelists. I am Carlota Dao. I am an assistant professor of human nutrition in the Department of Agriculture, Nutrition, and Food Systems at the University of New Hampshire. I transitioned there last summer, and prior to my faculty position, I was actually at Tufts, and I'm a former Tufts graduate student as well. And to tell you a little bit about the work that I do and that I'm going to be doing at UNH, I'm interested in addressing nutrition-related health disparities, particularly related to obesity and cardiometabolic risks, and I focus on Hispanic and Latino populations in the US. I have various initiatives in planning or being launched that relate to this question. For example, I'm looking at the relationship between diet quality, psychosocial and metabolic factors, and the gut microbiome in New Hampshire Hispanic communities. This is important, and I can elaborate on that later, but particularly with gut microbiota and other of these factors, there's a great need to include underrepresented populations in research and health disparity populations in this type of project. I'm also looking at perceived psychosocial and physical well-being in relation to the food environment and weight status during COVID, also in New Hampshire. And prior to transitioning here, I was actually working with Dr. Susan Roberts at the Human Nutrition Research Center on Aging. During this time, we were very focused on cultural adaptations of lifestyle interventions. And so we worked on an adaptation for older Hispanic adults in the greater Boston area. And in general, this is kind of where I want to go. How do we tailor interventions to psychosocial lifestyle characteristics as well as biological information?
Awesome, thank you. Jenny, would you like to go next?
Hi, everyone. Thank you for the invite. My name is Jenny Zhen. I work in the Disparities Research Unit with Maggie Legria at Mass General Hospital, and I'm also an instructor at Harvard Medical School. In general, I use a community engaged approach from all my studies, and the degree of engagement varies depending on the project, from little engagement, just getting input and support from community members, and to a lot of engagement. I've done a lot of community-based participatory research in the past with Latinx co-researchers as our partners. And in terms of my topic areas, all of my projects, I'm trained I am a clinical psychologist. All my projects are focused on improving the health and mental health of Latinx in the US. And and other racial ethnic minority groups. Currently, my research program, I'm looking at childhood adversities. It can be defined as like maltreatment, abuse and neglect, but also poverty, other socioeconomic stressors as adversities, and how that impacts the stress response system and epigenetic mechanisms in the body of Latinx youth, and how that in turn predicts alcohol and drug use. So that's broadly what I'm focusing on right now. But I've done a lot of research projects, including looking at educational outcomes in Latinx youth, health behavior, like dieting and exercising as well. But right now I'm focusing more on addiction as an outcome.
Excellent, thank you. Pablo?
Yeah, sorry, I was looking for the mic.
No worries.
Hello, can you hear me well?
Yes.
Perfect. Thank you for inviting me. I'm happy to be here. My name is Pablo Méndez-Lázaro. I'm an associate professor at the University of Puerto Rico Medical Science Campus. I work in environmental health. I've been working there for 12 years. And my research area is mainly focusing on climate change and climate impacts on public health and socio-ecological system. What else do I need to say? Also, the kind of research that I do. Currently, I'm the PI of 2 different NASA research projects funded by Earth Science Division. I'm working on African dust and developing early warning system for African dust arrival to the Caribbean. The second one is also working with air pollution, air quality, and the severity of the symptoms of patients with COVID-19 in Puerto Rico and in the Caribbean. It's also funded by NASA. So I'm also part of the Committee on Climate Change Adaptation in Puerto Rico from the government. This is a committee that was created and designed after 2019, during the summer of 2019, by law number 33. And it's composed by 6 different permanent members. All of them were selected by the governor, and then they were confirmed by the House and the Senate in Puerto Rico. And this is a mandate that we have for the next 5 years. And so we need to work on that. Beyond that, working with many communities in Puerto Rico, basically we are using human-centered design approach. Is that if we want to work with some problems, climate related or environmental health related with the communities, we first start working with the communities, and then we start proposing ideas and solutions. But again, it's a human-centered design, so it's not us as scientists or the government proposing the solution to the community, but it's instead, as Jenny was mentioned, it's a participatory approach where we allow the people to communicate their own issue and to propose their own solution. And so, I don't know, right after Hurricane Maria, we created public health brigades in Puerto Rico, and we impacted almost all of the 78 municipalities. We were also able to visit a couple of islands in the Caribbean after Hurricane Irma. And because of that, we were invited by the Congress of the United States to expose the situation after the hurricane in Puerto Rico. Obviously, because they didn't trust that much in the government version on what the thing was going on in Puerto Rico after the hurricane. So they invited a couple of NGOs and academics and other and community residents and leaders that were working on the response phase with the communities and not people from the government. So I had the opportunity also to explore all the situation in November 2017. And I think that we can say more after the others.
Thank you.
Happy to be here.
I'm glad. Thank you for being here. Sara, would you like to go next?
Sure. Thank you, Angelica. I'm an associate professor at the Friedman School of Nutrition, and my area of expertise is behavioral theory, behavioral psychology, and that infuses all the work that I do. And I do community-based interventions. And relevant to this this panel, a key area is developing interventions for cardiovascular disease prevention among African American women. And there's 2 interventions that I am currently working on, and one uses civic engagement, and for a variety of theory-based reasons. The idea is that by having groups of women work in their communities to make changes in those communities, that will then feed back and lead to individual level change. So that's one of them. And then the second is an adaptation of another intervention for the general population of women, but specifically for African American women, called Healthy Hearts for an Abundant Life. And in both the civic engagement, we call it the change clubs and Healthy Hearts for an Abundant Life, there's an emphasis on social determinants of health. I think in the civic engagement one, change clubs, and actually having groups consider what's going on in the communities and make change. And then in Healthy Hearts for an Abundant Life, it is an individually focused intervention, but it based on a lot of formative work and a lot of input from stakeholders and so forth. It does consider and the things in the environment that are so critical to behaviors are talked about and considered in the program. So, and then just to wrap up, I also have some research going on very low income populations and diet quality. And again, with my lens, thinking about it from behavioral economics perspective. So I always have kind of the behavioral psychology angle in there.
Great, thank you, Sarah. And now to wrap us up with this question, Josiemer.
Hi, good afternoon, everybody. And first of all, thank you so much for inviting me. It's great to see so many names and faces that I recognize and to be back. I'm a triple jumbo. If for those of you who graduated from Tufts, they know what I mean. And I graduated in 2009, and I love you all. I miss you. Right now, I'm an associate professor of nutrition at the Harvard Chan School of Public Health. I've been there for a few years. And I'm a nutritionist at heart, and my research combines two areas. So it's nutritional epidemiology, and we do a lot of work with observational cohorts and epidemiological data, but I also do community nutrition and community interventions on nutrition based on the information that we gather from the epidemiological studies. So I straddle both areas. And I use a lot of also mixed methods to do this. So we use quantitative and qualitative techniques, tools to do our work. Right now, I'm focusing on traditional diets and what is really, minority populations are consuming and what they consider culturally appropriate, but also healthy, that would improve the health disparities and decrease the health disparities that we observe in minority populations. I focus specifically on Latinos, and I know Latinos are huge, so I actually do this at levels. I work with Latinos here in Boston, specifically focus on the similarities and difference that we see across the Hispanic community. So what are the differences and the similarities in consumption and in disease rates for a Puerto Rican versus a Mexican versus a Peruvian and so forth. And we try to tailor our interventions specifically for those communities. So in addition to working at the local level, we also work at the national level using several cohorts. And I also work in the country of origins. So I have several cohorts and interventions in Puerto Rico, which is where I'm from. You can probably get that from my accent. Hola, Pablo, I love your background. I can recognize that. And also in several countries in Latin America, we have strong collaborations in Mexico, Costa Rica, Uruguay, Brazil, and Venezuela. So we try to put all the pictures together in terms of what's happening in the countries of origins in terms of diet and disease, and how that might translate to immigrant Latino populations here in the US. So I think that gives you a little bit of perspective, and we can talk more about the details later.
Awesome, thank you. Okay, so for the second question, we're going to start with Jenny. And to all of you, how are disparities manifested in your area of work? Can you tell us a little about where they may come from?
I was thinking about that before the panel started, in terms of like the ideology, I guess, or where it comes from. I think is a very complex question and something that we're constantly trying to understand. So I'll start with the first question then. In terms of like how it's manifested in my field, like I mentioned earlier, I look at the outcome being health behaviors, including alcohol and drug use, mental health symptoms as an outcome. That's how it manifests. But also we look at service, mental health services as an outcome in disparities when we're looking at racial and ethnic minorities in the US. In terms of where it comes from, I think it depends on the question. I think that a lot of the work that we have done in terms of healthcare and mental health care delivery for Latinx groups, we attribute these difficulties mainly on systemic issues, not, I think that maybe 10, 20 years ago, there's a lot of focus on patient non-adherence and like people not wanting to get better. And now we're shifting the conversation and really looking at how can we as providers make it easier for people to access services if they want to, rather than blaming minoritized populations. Does that answer your question?
It does. Thank
Okay.
you.
I'm sorry I'm being very vague. I think it depends on like what we're looking at in terms of reasons for the disparities. I think it varies a lot, but I think that in general, you know, systemic oppression, histories of marginalization has a lot to do with these disparities in terms of how people manifest their symptoms, how they're labeled by clinicians, and how they access care.
Awesome. Thank you so much for that reflection. It is definitely a really big question. So that's why I asked it, because I feel like we throw around terms very often in academic circles and groups like disparities. But what does that really mean in practice, right? And that's kind of what I want to get to. So that's, you know, within your field or within your area, within your piece, how does that communicate with everyone else's, right? So Pablo, can you talk to us?
Yeah, sure. Thank you for that question, Angelica. And I also agree with Jenny, it's a complex question, but there is not a magic stick to answer this. Well, from my point of view and working here in Puerto Rico, what I can use as an example is one of the most catastrophic recent disaster that we have in Puerto Rico recently, right? Not in the whole history, but I believe very recently, and it was Hurricane Maria. So what Hurricane Maria unveiled in Puerto Rico was how disadvantaged communities were struggling to survive and without any kind of access, or were in a dire situations for electricity and water or essential services. So Hurricane Maria didn't destroy the island of Puerto Rico. I think that we were destroyed a couple of years ago. And so Hurricane Maria only finalized or end or unveiled the situation, how the people were living outside of metropolitan areas like San Juan or Ponce. I'm not talking here in San Juan where I live or in other urban areas of Puerto Rico, but obviously the most impacted areas in terms of, not in terms of the physical hazard, but in terms of the secondary stressor that came during the aftermath of the hurricane, accessibility to supplies, accessibility to resources, energy, water, public health, or whatever kind of other essential services that you might need. It was so complicated for them to get access. It was almost impossible. So disadvantaged communities suffer in a completely different way than high income communities in Puerto Rico. And that is also related with the social determinants of health. So from my perspective, which I work with climate change and extreme events, impacts on public health and socio-ecological system, I think that obviously we need to focus on the extreme event per se, on how to prepare for that and for those kind of hazards that are potentially impacting the zone, but also we need to improve our quality of life of all of the residents. if we want to be better adapted for those kind of extreme events, right? So adaptive capacity is very related with sensitivity, exposure, and all of the different social determinants of health. So income, accessibility to resources, accessibility to information. Something that happened in Hurricane Maria is that I think that we have improved very much with providing information related with the hurricane, with the phenomenon. Everybody knows how strong is the wind, how much rainfall is gonna fall, where with not that accurate, but with a very little margin of error, because we're talking of a very powerful hurricane, right? So it's a category 5. So almost everybody's gonna get flooded. But how do you prepare yourself for those kind of hazards? I think that that information is available. But what we haven't improved yet is on the secondary stressor of what had happened during, after, and then in the aftermath of the storm, right? So everybody have information about the storm. National Hurricane Center, National Weather Service are doing a pretty good job, doing an excellent job analyzing the phenomenon and providing the information to the audience. But we forget about how to prepare our public, our population for the other kind of stressors that are related with the disaster during the aftermath. Accessibility to resources, again, electricity, water, suminister, transportation, and epidemics. And so all those kind of things that are during the aftermath, I think that are very important in us. And we need to highlight that because that kind of information is the information that the disadvantaged community lack before the hurricane. Because those with the adaptive capacity or high income of access to resources, they were able to respond in a very faster way than the communities that were from poor income communities, right? So again, I think that if, from my point of view, if we want to be better prepared in the discipline that I work, which is climate and health, I think that we should not only focus on the climate, on the hazard, but we should focus also on the other kind of conditions that interact directly with the hazard, the environmental and institutional context, but also the social and behavioral context, the individual component, the social determinants of health, as Sara was mentioned as well. It's the only way to be better prepared. Yeah.
Thank you so much. So, hey, we're already seeing that there are different ways of identifying groups that could be suffering from disparities, and the kinds of disparities also vary depending on the context and depending on the area of study. So, Sara, can you tell us about yours?
Sure. And it can be boiled down, with the origin of disparities can be boiled down simply to racism. And it manifests in pretty much any way you can think of, with cardiovascular disease, from the ongoing effects of living in a racist society and the stress that causes. So that obviously impacts heart health to a great degree. But beyond that, how it impacts even individual behaviors. And just an example of, I think everyone's probably familiar with redlining as a policy, very clear racist policy where Black people were denied housing loans, which led to, it manifests to this day and impacts many areas, including heart health. And it happened here in Boston. And you can, looking at data, there are very clear data as to who's most impacted by cardiovascular disease by neighborhood in Boston, that maps directly to these policies from many years ago. And in terms of cardiovascular health, it also manifests, or just a couple examples of ways that it does. A direct result of the redlining policy and the segregation that resulted was food deserts and the loss of grocery stores and other food outlets from communities. And to this day, if you again go to those neighborhoods in Boston affected by it, there are fewer grocery stores, and the quality of the food, especially healthy produce and things like that is less. And, you know, in working directly in and with these communities, people know that, like they know that. And it's like, if you're in a supermarket in Roxbury, the fresh produce is lower quality and higher cost than other areas of Boston. And you can see that it can be documented, and people in the communities are well aware of it. And then, you know, just the ripple effects of one policy, you know, the lack of the ability to get the loan also led to an inability, you know, the ability to purchase and own property is a way to build generational wealth, and being shut out of that ability, leading to continuing poverty and you know, and an inability to break out of that, and of course poverty associated with lower diet quality, less ability to engage in physical activity, and just multiple ways that's impacted. So and redlining is just one example of a policy. So many of the policies from the past, which were very blatant, have continued to have negative effects, and continue to perpetuate disparities. And that's just one example. So and there are other policies that are more recent. So it just keeps getting perpetuated, and definitely is something that needs addressing.
Thank you. Thank you so much for that reflection. Absolutely true. It's not just what we carry with us from the past, it's also how it manifests as we're moving forward. So thank you. Josiemer.
Thank you. And I think that the panelists so far have answered this beautifully. So I have very little to add, but just kind of like put it together. In my view, honestly, these disparities come from everywhere, and we really cannot point to one single thing. You know, this is just happening at every single level. And we usually, when we speak about the health disparities, we're really talking about the differences that we see in disease rate or in an outcome. But what we have to look is just the upstream causes of what is really leading to those health disparities. And that's what I mean, that this is really coming from everywhere. And Pablo used the Puerto Rico example. I do a lot of work in Puerto Rico, and it's really a good example because you see these layers happening very clearly. So to give you an example, you know, unhealthy behaviors in Puerto Rico are very prevalent. You know, what we have one of the lowest diet quality rates, you know, the quality of the diet is very poor, lowest physical activity rates in the island. And obviously we know that those contribute to chronic disease. But that's not the only thing. We also have a lot of chronic stressors. We have a lot of psychosocial factors that also contribute to that. But then we can layer this even deeper down. Where are these psychosocial stressors and where it is happening? Like as Pablo was saying, we have a lot of socio-political instability in the island that contributes to this, and economic instability that contributes to this. So you keep just going down and down and down this hierarchy and finding where the disparities are happening. And you can go as deep as the infrastructure. So yes, we have low physical activity, but why is this happening? We have very poor infrastructure on sidewalks. We don't have safe parks for people to go and walk. We have a reliance on imported foods, which are usually of lower quality and higher prices because of the tariffs that people have to pay for these foods to be imported. So you keep just going to those layers and finding all of these disparities, and really cannot point to one thing, but just to this whole picture of why the disparities are being what is contributing to the disparities.
Thank you. And I also think that that points to the necessity for people from different fields and with different lenses to take a look at that big picture. So, Carlota.
Yes, thank you. Likewise, I don't have much to add. I would like to echo the other panelists' comments. I think from my lens, which is looking at overweight and obesity and associated health risks, we know that there's an epidemic in this country and around the world, and that it has disproportionately impacted different groups, particularly racial, ethnic minorities. And obesity is multifactorial, and this gets a lot at how the other comments that were being made, how there's a multitude of biological, psychosocial, environmental, lifestyle factors that underlie obesity. And this is not, these factors do not weigh equally across subpopulations. There's unique environments, unique situations that need to be addressed. And so there's great efforts to address and the reason why we want to address obesity is because of it leads to increased risk for a multitude of other factors. And so one thing that is becoming clearer and clearer is that unless we tailor advice and we recognize not only perhaps individual conditions, but also the background, the context, those strategies are perhaps not going to work, because if you're giving advice to individuals that do not have control over the obesogenic environment that they're in, those strategies are going to be futile. So, yeah.
Thank you. Thank you so much. It's extremely important to set things in context. And I'm glad to hear from all of you that you've definitely thought a lot about that. So, so to move on to our next question, you've sort of mentioned it in the explanations that you've given, but I would love it if we could be a little bit more specific about which minority groups you particularly work with. How do you define those minority groups? And in particular, I would love to have a conversation about what your motivation is for doing so. Why do you work with these minority groups, however it is that they are defined? How do you relate to these groups? And how important do you think it is for research teams to
Angelica, I don't think we can hear, we can't hear you right now.
Yeah.
Oh no,
Yeah,
I
there
cut
you go.
off. Okay,
Yeah,
am I
yeah.
back?
Yeah,
Great.
you're back.
Okay.
Yeah, you cut off when you were saying how important it is for us to
How important it is for research teams to engage in reflexivity and to recognize their positionality. So how important is it for researchers to look in the mirror and say, this is who I am, these are the people that I'm working with, and how is this relationship between us in terms of power, in terms of agency? So yeah, I'd love to hear your reflections on that. Pablo, do you want to start?
Yeah, thank you. Okay, again, that's complicated, but who gave you those questions?
I brought them.
Just kidding, just kidding. Okay, well, let me see, how do I start? So again, I will stay focused with the extreme event of Hurricane Maria, because it's one of the clearest example in Puerto Rico. So during the first couple of months after the hurricane, we continue working, we work with the community, with some disadvantaged communities, providing supplies and providing public health access and physicians, nurses, and whatever the kind of other health issues that they might need. But right after a couple of months, we stayed working with only a couple of the communities that were impacted by our group. And why so? Because, for example, in rural communities in Utuado, Jayuyas, and Ciale, which are, for most of you perhaps are not aware, this is in the central Ridge Mountains of Puerto Rico, very rural communities. This community was lacking of a health clinic, for example. And before the hurricane, they needed to drive almost 1.5 hours to go to the closest health clinic in rural roads and streets without any lights or anything. So you can imagine right after the hurricane, these communities request for the government, for the local government to build them a health clinic, and the local government denied it. Also, the federal government throughout the 330 centers also denied, because they didn't comply with the minimum requirements of having 25,000 people or more. And so these are 7,000 people in the central part of the island. So after we started working with them, providing supplies and everything and those kind of things, we then sit down and start thinking with them strategically. What do you need? How we can help you? And so they identified the lack of health services. So what we did is that we submit a proposal to a foundation, Heart to Heart International, and with the community leader, with the community-based organization named COSAO, and we got it. We received a funding, and so then we met with the mayor of Utuado, of the municipality, and they provide us an abandoned coffee roaster. And that coffee roaster was the community with their own hands. They rehabilitate the facilities, and then with other funders and sponsors, we were able to install solar panels and rain harvesting system. And so between all of the different sponsors and the proposal that we submit, we were able to build a health clinic there for the community. After the health clinic was built, then all of the services are provided for free of charge, at least for 2 years for the community. After that, we then started working with the community, with health promoters, because one of the things, our major goal is not for the people to get and look for a pill or for disease management, right? We want prevention. So the community also was interested in public health preparedness. And so we decided to submit another proposal with the community-based organization to build and design a community health promoters program. And all of these programs are led by women that were unemployed in these disadvantaged communities. So now they have access to at least having some kind of job to select there. And also the community is receiving some services in terms of preparedness. The other needs or that the community was identifying also was socioeconomic development. So we're talking about communities in the central part of the island. So what we did also is we work again with farmers then in that region. And so what is the potential, what are the strengths of these communities? They have agricultural land and they have farmers. So we submit another proposal to SARE, which is Southern Sustainable Agricultural and Research and Education Program, as part of the USDA, and we receive an award in order to promote agritourism in these 7 communities. We're talking about 7 communities in the central part of the island. So now we are working on or improving socioeconomic development, and by stimulating and diversifying the job section in the area. So we have worked with disease management with the clinic, we have worked with public health prevention, with health promoters, and we are now working also with socioeconomic development in those communities. So at least working with the community is beautiful, it's different. As I mentioned before, I have very technological, scientific research funded by NASA, but on other initiatives, I'm working with communities, and I think it's very gratifying because it's completely different. There's nothing to do with those kind of things that you're working with when you're doing this kind of research. But working with the community is you are not submitting a manuscript research, you are not submitting a paper. Tons of or hundreds of scientists did that during the hurricane in Puerto Rico. Obviously, they took advantage of the situation, and they were only looking for how to get a grant after the situation. In my case, I didn't do that. I stayed working with the communities, and again, that's my experience. And I think it's gratifying. And I think that the power is in the community. They were faster, they were able to do what they're looking for. And for example, they were waiting for the government to help them. And as I mentioned, both government, the federal government and the state government, both of them declined and denied to build the health clinic. So they say, you know what, we need to continue, we need to move forward. So they look for other options. And the third sector opened a new door for those community-based organizations. So yeah, I don't know if I answered your question, but.
I'm going to try to answer it from all the wonderful things that you said. And what I heard was that it's very important to strengthen your relationships with your community, and you feel comfortable in talking to the people with your community and consider them part of your community.
Yeah, I think that you need to be trusted by the community, obviously, and that's something that is not easy. And in Puerto Rico, it's getting more difficult and difficult. Maybe not for me, but for other colleagues, because so many people were using the communities for research as if they were mosquitoes in the lab or rats in the lab right after the hurricane, that some communities just closed the door, and they are now using some gatekeeper that if you don't talk to them, they will not allow you to work with them. And so we call that anchor organizations. Those anchor organizations and the gatekeeper, and somehow are protecting the communities, yes. But that channel of communication needs to stay open, and it's based on trust, obviously.
Thank you so much. Yeah. Something that I heard that I really liked is community work happens at the speed of trust. So I definitely hear that from what you said. Okay, I want to make sure that we're mindful of time because I tend to get really into people's stories. So yeah, we're coming up soon on this, and I want to make sure I hear from everyone. So Sarah, would you like to try to answer this question?
Sure. And as was noted, it very complex and thought-provoking question, and not easy to answer and quickly. And I'll try to be relatively quick though. So as I mentioned, I work with African American women as the group, and the motivation for doing that. Again, I had a heart health program for women in the general population, and we got CDC funding to do a dissemination study of the program. And it was in doing the dissemination study that the data showed that African American women were enrolling at rates proportional to the population where we were running the intervention. But if they joined, they were dropping out at twice the rate, and if they stayed, they didn't get the same benefit. So so it was from that study and realizing, and then all kinds of realizations came from there, including I kind of knew there were disparities, but I really dug into the data on that, and it's pretty stark and distressing. So realizing, the data themselves point to the need and the issues, and hearing from communities where the program was run, and hearing more about how it wasn't meeting their needs. And then also there's other data that intervention studies, like mine wasn't the only one. There's a lot of intervention studies, including very large NIH funded interventions, that show the same thing, that if you put everyone together in the intervention, there's certain racial ethnic minorities tend to are dropping out at a higher rate and not realizing the same benefit, so clearly not meeting their needs. So that was kind of the motivation. And in reflexivity, I'll try to be very brief, but clearly I'm white, working in a Black African American community, and so that's something that's constantly on my mind. And I think overall, and it's interesting, the positionality, and I'm working on a privilege scale in dietetics with some people from outside of Tufts, and as a result, did a privilege, to see how privileged I am. And it's interesting because I came out as not privileged. Clearly I have racial privilege, but just based on my background and other things, I didn't come out as privileged. So so that was interesting, but clearly the having white privilege is major as well. So that's something always to be thinking about and mindful of. And I try to address it by never letting up on myself in terms of asking the questions and examining my own motives, and doing that reflexivity on an ongoing basis, making sure, often I'm the only white person on the research team. So making sure the research team is reflective of the population, and inclusion of stakeholders, so that the research is informed and and in part driven by people that it's meant to work with and affect. So I could go on for a long time, but want to give others a chance.
Thank you so much, Sarah, for taking us through your process. It's nice to hear something that you do already and how it's working for you. So thank you for sharing that. Josiemer?
Thank you, Angelica. I'll be as brief as possible. If I go too long, please wave at me and I'll stop talking because I talk a lot. But I'll try to tackle your questions in 3 points. You talk about motivation. To me, it's very personal. Obviously, I am Latina. I'm Puerto Rican, and to me, you know, seeing the things that are happening in my community, seeing the lack of action and the you know, discrimination and racism and everything that is happening around my community, that is a huge motivator. That's a call to action, pretty much for many of us. So the way that I see it is, I'm going to use this analogy, it's like an onion. So I look at the onion and I look at the whole picture of what's happening in the Hispanic community. But then I start peeling the layers of what that is. You know, I am a Latina overall, and I look at that, but I'm also Puerto Rican. So that's my next layer. And then I focus on that. But then I'm a Puerto Rican that lives in the US, and I don't have the same daily experiences that a person in Puerto Rico would have. So I look at those layers and how that ends up being this whole disparities that Hispanics are happening. And that relates to what you're talking about, reflexivity and positionality, because I look at a lot at that, you know, the reflexivity in the sense of, you know, recognizing the own beliefs and biases that you bring as a Hispanic or a African American or an Asian or a Thai person, whatever you might be. And what are you bringing on? And, you know, there are a lot of things that we carry with us that are positive and that are negative. So I carry the passion, I carry the motivation, but I may also have some implicit biases that are there. Oh, we don't eat healthy foods. That's an implicit bias that I have because I work in this field and that's what I see. And usually what I try to do that is kind of flip it to see, you know, we have that, but we also have a lot of good foods and healthy foods. What can we bring? I have to stop thinking that we all eat badly. So, you know, you have to recognize what these implicit biases are. And in terms of the positionality, 30 seconds and I'll wrap up. In terms of the positionality, it's really, you know, about understanding where are we coming from and what is our, like you're saying, your lens and your perspective. I am Puerto Rican. And that makes me very relatable. And Pablo was saying, you know, a lot of people came after the hurricane and did research. I'm one of them, but I never had a bad experience. Pablo, I'm gonna take that personally. It was never a bad experience. It was actually a very open experience because I have this background. I know the cultural norms. I know what's happening. It's like I've never left my island. And I know what is also happening with the Puerto Rican community here in Boston and in the US. So I can relate to that, but I also recognize that there are many things that I don't know. And I think that's what we need to think when we're talking about our research. Our positionality, we cannot be everywhere. And there are things and perspectives that we're not gonna have. And like Sarah was saying, what you need is just bring in people that will give you, that will have that positionality and will give you that perspective. So I partner with people who were living that daily lives every single day, that were not coming from the Ivy League perspective that I might have, and that was an actual disadvantage for me when I was going there. So when you surround yourself with diversity, and this is why I say diversity matters for everything, that really enriches your positionality and your reflexibility views.
Thank you so much for that. I feel that. I definitely feel that. I was in Puerto Rico during Hurricane Maria, so I understand that aspect of this whole work as well. And so thank you for that. And
short story, I was in Puerto Rico 1 week before Maria. We left the day that they announced that the hurricane was coming, and we had no idea. So I missed it. I am glad, and I am very sorry for people who were there. Well, my whole family is there. So.
Yeah, thank you. It's a tough moment, and so many things have come out of it. Hopefully positive learning. So Carlota, would you like to try to tackle this question?
Yes, I will do so. Also try to do it in a timely manner. So to answer the first part of your question, I primarily focus on Hispanic Latinos in the US. I am Latina as well. I'm from Venezuela originally, and these research efforts and questions are something that are very near and dear to my heart. I recognize, of course, the vast complexity and heterogeneity of the Hispanic population in the US, as Josiemer was saying earlier. And I think partly because of that, and partly because, as Pablo was saying, it is so important to form a relationship with trust and come close and really understand what communities are dealing with and what they're working with. I think it's all those things are really important in carrying out research around healthy nutrition, weight management. It's become very clear to me, even through research projects that I've led, that in particular with this field, the researchers, the interventionists do have an effect, even because of our interventionist characteristics or researcher backgrounds may impact the response to the particular nutritional intervention that you're doing. And so it is important to recognize the effect of the interventionist, the researcher, where you're coming from, as others were saying. And with regard to positionality and informing trust with communities, I think that's very important. Even though I am Venezuelan, I have had very likely a very different journey, especially while being in this country, than the communities I work with have. And so I really think that aspect of working with community leaders, community organizations, getting to know people and making them understand that you're not just there doing research and then you're going, and they're not going to see you again, that you're really invested and you really try, not that you understand what's happening, but that you're really trying and you're there to listen. I think it's very important. And I am very fortunate. The last thing I'll say, I'm very fortunate to work closely with cooperative extension at UNH. This is a department that has the mission of making work at the university relevant to communities, the well-being of communities. So I'm very grateful that there's this kind of mechanism to establish these links and kind of help you form those relationships in a lasting way.
All right, so thank you so much. And now we've got a couple minutes left for Jenny to wrap us up.
All right. Okay. So the first question was why this group? I actually don't look like your typical Latina, but I am Puerto Rican too. My parents are Chinese immigrants. Why did I get into multicultural psychology, which was the field I got into, was because I was the undergrad student at the University of Puerto Rico reading books that were produced and published in the US, the US white populations. And I was really wondering why we were using these like gold standards made in the US to like as like gold standards in Puerto Rico, like treatments, psychological treatment. So I was really, really invested in getting into this study to make sure that we change and diversify the science of psychology, not only by my presence, but also by producing research that is inclusive of other racial and ethnic minorities. And that's the why. So I'm very also, like Josiemer, very committed because it's very personal to me. In terms of the question about power and agency, is really I don't know, bringing up a lot of things for me, that question, because I did a lot of CBPR work in Cincinnati where I obtained my PhD, and our partners, like I said, were immigrant Latinx adults, and we were jointly deciding what the research questions were going to be, how their interventions were going to be developed. And I think I had to constantly remind myself and that I was an expert in the scientific part, not the problem part. I identify as Latina, but I was not part of the community. I'm not invited unless they invite me. And then that's the thing that that I had to kept in my mind. And there, so one example, as a scientist and the CBPR person, we wanted to get information about the income information of the participants in our study. And they were like, no, we're not gonna do that because these are people we know. So we had to drop a lot of questions that we had as researcher because they are also researchers and they have a say in how this research is designed. And this is not how science is taught typically. But it's an important science because we can reach people. Another thing is that I grew up low income. I'm an immigrant, first generation, had a lot of disadvantaged statuses, but I'm not anymore. I'm very privileged right now. And I have to constantly remind myself, I don't have to leave my house at all for anything during COVID if I don't want to. I enjoy that privilege that I maybe would have not enjoyed that growing up, but I do now. So when I identify with the groups I'm studying, I also have to keep in mind and check my privilege all the time, constantly. So that's all I'm gonna say about this.
Thank you so much, all of you, for everything that you have shared so far. This has been a fantastic conversation. And I'm really excited that we were able to talk about these topics and start, to really address these because like you said, these are really big questions and they are continuously in development. So thank you for getting personal. Thank you for talking about your own motivations and your own experiences. And I want to remind everyone that we're going to be posting a recording of this panel and it's going to be on the conference website. You will also be able to see a little bit more about our panelists, a little bit more about their bios and their names and official titles. But I'm glad that we purposely didn't go into the big official titles on our end, more to get to you, to your perspectives and you as people as well as researchers. So thank you all. And I think we should wrap up for now. There's lots of questions still, especially around data and data use. So I'll leave you with that. Thank you all very much.